So I'm going to talk about new antiretrovirals and new strategies. And there has, I hope I am not making a mistake here. Yep. This is the outline of my talk. A few years ago, we thought that there were not going to be very many new antiretrovirals, that we were getting into incredible antiretrovirals, one pill once a day, well tolerated. And I was very wrong. It has been an incredible year. It's like the old song from Frank Sinatra. These are the drugs that have been approved in the last year and a half, starting from combinations with new integrase inhibitors, single tablets with protease inhibitors, a new NRTI, and new strategies to manage HIV infection, challenging the paradigm of treating with 3 drugs that has been the paradigm to treat HIV infection for more than 20 years. And there has been new drugs for people that have very few treatment options. And this is what I am going to talk about. I'm not going to talk about future drugs and leaving that for tomorrow, because to do this in 20 minutes is not that easy. So new antiretrovirals. Almost 18 months ago, this drug, Biktarvy, which is a fixed-dose combination of TAF, FTC, and bictegravir, was approved. And this was one of the 2 pivotal trials that was used to approve this drug. It was a direct comparison between this new single tablet and the standard at that time, which was a combination of abacavir, 3TC, and dolutegravir. It's called TRIUMEC. Large size study, around 700 people, antiretroviral naive. Of course, they couldn't have, because they couldn't get randomized to abacavir. They had to be HLA B5701 negative, and they cannot have hepatitis B infection. And it was a non-inferiority trial, and the results were presented and published even before the drug was approved, and it was a complete tie. The new drug, which is a single tablet regimen, a little bit smaller, was as good as the standard of care at that time, and success rates with undetectable viral loads in the mid-90%, and very few virological failures. This delta here between 92 and 90 and 100 is really people that were lost to follow-up or move or were not seen within the window of the visit. Very little resistance. With these regimens, there was no emergencies of resistance with any of these 2 drugs. The drugs are very similar, and when people fail these regimens, we were not seeing a significant amount of resistance, and there was a significant immune recovery. So this study and another study that compared to other comparison with bictegravir led to the approval of this drug at the beginning of 2018. The other drug that has been approved in July last year, 1 year ago, was Simtusa, which is a combination, fixed-dose combination of tenofovir, darunavir with covisistat and FTC. The dose of TAF in this pill is a little bit different, and you have to remember that when you start using in people with multi-drug resistant these drugs. So the dose here of TAF is 10 milligrams, and the dose of TAF in the bictegravir combination is 25 milligrams. So, but again, a massive study, 700 people, 720 people. They were randomized to this drug as a single tablet or as the old combination of tenofovir FTC with darunavir covisistat as a separate tablet. Is randomized double-blind. And again, treatment-naive adults with normal creatinine clearance were randomized to these 2 arms. And again, this was what led to the approval of this new single tablet regimen. Success rates, virological success rates around 90%. Very few little virological failures, around 3 or 4%. And confidence intervals that doesn't reach the non-inferiority margin of 10%, and basically shows equivalence between these 2 regimens. And again, here, there was very little evidence of resistance during virological failure. We knew this because when you fail a protease inhibitor-based regimen, and now an integrase inhibitor-based regimen with high genetic barriers of resistance, you don't see a lot of virological resistance, significant virological resistance. The next drug that was approved, and that was a year ago, almost to the date today, it was Delstrigo. It's a combination, it's a new NNRTI in the same class of efavirenz, nevirapine, rilpivirine, and it was a very, the trial that was used, sorry, I'm getting confused with this thing. No, I will get. It was against a tripla, so it was a combination of tenofovir FTC and efavirenz. Again, the same sample size, around 700 people, and it was a non-inferiority trial. It went basically for tolerability in this study, and the success rate was around 85–80%. As Pedro pointed out, the success rate is a little bit lower than we are expecting now in antiretroviral trials, closer to 90–95%. Has to do with the selection of the population, but also you can see a little bit more of virological failures. The drug is very well tolerated. It was equivalent to efavirenz. Less neurologic side effects than efavirenz, and is probably the best in class of NNRTIs, but is not used as much as integrase inhibitors, and we will discuss later of how these drugs are going to be used in the future. The question of all these new drugs is how these new drugs fit in the current treatment guidelines. How should they be used? And these are the guidelines, the DHHS, this is a panel that I belong to, the International Society, the European guidelines, and the WHO guidelines. And as you can see here, it is a big theme that almost all guidelines recommend as first-line regimens integrase inhibitor-based regimens. The Europeans are a little bit more conservative and still recommend occasional NNRTIs and protease inhibitors. But there is a confluence of the guidelines that the first and the best initial treatment regimen for most people living with HIV infection is an integrase inhibitor-based regimen. So how, I don't have a crystal ball and I don't know how these drugs are going to be used in the future. You guys decide how these drugs are being used. And I think Biktarvy, the combination of TAF, FTC, and Biktarvy is one of the options for most patients living with HIV as a starting regimen, and that's how the guidelines have looked at these drugs. Delstrigo is still trying to find a place in the treatment field, and I think it's an option for people with multiple comorbidities when you are a little bit worried about multiple drugs because it has very few interactions and is a very well-tolerated drug. It might become more popular, particularly if the weight signal that has been seen in some of the naive trials of weight gain associated with the use of integrase inhibitor, or in Mexico, they presented data that link the weight gain to TAF use, particularly when it's in combination with an integrase inhibitor. If that becomes a big issue for some particular populations, particularly black women, this drug, there might be a return to the NNRTI class, and this is a good NNRTI. And boosted protease inhibitors, I think we are going away from using boosters as first-line therapy because of the drug interactions and tolerability, GI tolerability. But this drug is an attractive drug for rapid initiation of antiretroviral therapy if in the community that you practice doesn't have a lot of primary resistance to protease inhibitors. And if you have questions about adherence, traditionally, protease inhibitors and these integrase inhibitors that have a high genetic barrier, like dolutegravir or bictegravir, are drugs that are very well suited for the rapid initiation of antiretroviral therapy when you don't have all the data. And that's, in summary, the new drugs that have been approved and are in the field in the last year or so. New strategies. And there has been an incredible amount of presentations about these questions. Can you induce and maintain suppression with two drugs? So in the Gemini studies that were done by Pedro Khan, and he should be presenting this, the 96-week data was presented in the Mexico meeting 1 month ago, literally, and they led to the approval, the 48-week data, to the approval of this fixed-dose combination of dolutegravir and 3TC. Again, two very similar studies, Gemini 1 and Gemini 2, 700 people, so they presented analysis combining them, so 1,500 people. There is not very many trials out there of 1,500 people. I think there are a couple, so these are massive studies. And randomized people to triple therapy, tenofovir FTC and dolutegravir, or dual therapy. These are naive patients with viral loads between 1,000 and 500,000 without hepatitis B and without resistance. They were randomized to these two arms, and it was gutsy to do that study because I don't think many people thought they were going to be equivalent. And this is the results. Overall, around 90% undetectability at 96 weeks, which is a lot longer than the typical 40 weeks. And if you had a high viral load, really didn't make a difference. If you had more than 100,000, usually people respond less well to when they have high viral loads than with lower viral load, around the same rate of suppression. And if you have a high CD4 count, same rate of suppression. There was a question about lower effectiveness of the dual therapy in people with low CD4 count. The N becomes very small. And although it seems that there is a lower response rate, the number is small, and there was no evidence of virological failure. It was more people lost. But I think there is still a question about this group of people that have a low CD4 count at baseline. There was not a lot of resistance developed in any, there was no resistance, not a lot. There was no resistance in either arm. And the data from this study support the approval of this single tablet regimen, and it was approved in May of last year. It has not become very popular yet, I think because it's very difficult to change the way we think. We always think about triple therapy when we treat HIV. And also, I think many providers were waiting for the 96-week data. Yes, you can induce viral suppression, but maybe it will not be as durable. I think this presentation that was done in Mexico cleared that infection. Biff and the investigators also look at how long it took to become undetectable. And as you can see, basically in both arms, both groups became undetectable relatively quickly. And also look at the frequency of target not detected. You can be undetectable two ways. You can be undetectable and less than the limit of detection of the assay, but you can be less than the limit of detection of the assay and not even see the template that is going to do the PCR reaction. That's target not detected. And the frequency, which is a little bit more undetectable than the other one, the target not detected frequency between the two arms was exactly the same. So it doesn't seem that it's a question of potency. It seems that the 2 versus 3 is similar if you pick the right two medicines. There was another study looking at the combination of two. This is a switch study. The Tango, I thought because of this name, I thought Pedro Kang was an investigator, but no. It was not an investigator of the Tango study. And this was a switch. People that were suppressed on a TAF-based regimen with HIV less than 50 copies, no hepatitis B, and no history of virological failure. They were randomized to 2 drugs versus continue the TAF-based regimen. Again, 720 people in this study, an incredible tie. So this was, as we say in football, un empate completo. 93% in both maintained viral suppression. There was basically no virological failures. I think there was one. And then the absence of virological data, people that were not within the window or that were lost to follow-up was 7%. So really, when you are suppressed, when you have been suppressed on antiretroviral therapy for a while and you don't have evidence of resistance, switching to a 2-drug regimen will maintain suppression. And I suspect, I don't have a crystal ball, as I said before, I suspect this is the way a lot of people will use these combinations. The main advantage of this dolutegravir C3C is that it reduces the amount of total drug exposure and it reduces the cost. The cost of this drug, at least in the US, is lower than the cost of triple combination therapy. And hopefully will lower the cost of triple combination therapy because that's the way things work. So there are questions still. This is not a done deal. Would you use this regimen for a rapid start? If you are going to start somebody on therapy and you don't know the resistance in that particular individual, the question of transmitted M1T4B, which is very rare, but in a study in New York, in people that were receiving PrEP that acquire HIV, the prevalence of N184B is higher, which makes sense because they are being exposed and probably being treated with monotherapy, with dual therapy with tenofovir and 3TC, and we know in that case you develop 3TC resistance. Women of childbearing potential, and this is an issue with dolutegravir and probably all integrase inhibitors. There were some data presented in Mexico that decreases the risk of neural tubal defects associated with the use of dolutegravir, but it's not the background. So this is still a question in the field about the safety of some of the integrase inhibitors at the time of conception. Issues with co-infection with TB because there is an interaction with dolutegravir. And then these people were excluded from the study, people with higher viral loads, greater than 500,000. This is very rare in clinical practice, and I think most people will use a triple therapy in those cases. And also individuals with low CD4 count. I think the explanations of why that difference are clear, and there was not a lot of resistance and virological failure in that group. But I think we might need a little bit more data in people with very low CD4 count. And the question of hepatitis B co-infection. New treatments for the patient with very few options. I think there is light at the end of the tunnel. This drug was approved last year. How many people have used this drug in this room? You are one of the 100 in the United States because there is only 100 patients on this drug in the whole country. Oh, you have some. It's a drug, it's an antibody, CD4 antibody, and it works for people with multi-drug resistance. The paper was published last year, and it shows antiviral activity when you have very limited options. You have to give a loading dose of 2,000 milligrams, and then dosing every 14 days. And for people that are in this situation, it maintains suppression. In this study, they allow the use of other investigational drugs with activity against HIV, and if you have to deal with one of these patients, this is a treatment option for them, and you should consider it. It's incredibly expensive, and you have to think about how you're going to give it in your practice because it requires an IV infusion, but in the future, it might be intramuscular, and it might be easier. There was a presentation from fostensavir, is a drug, is a attachment inhibitors. It binds to the CD4 binding site of the HIV virus and prevents the attachment to the CD4. And it's a drug. We had some data, but this was the 96-week data was presented in Mexico meeting. This was a study design. This was for people that were incredibly incredible resistance and very few treatment options. The baseline viral load was almost 100,000, but look at the CD4, 80. The patients that I have treated with this drug, they have no CD4s. And when you look at the genotypes, it's like a line of black or red, depending on whether you order your genotypes. So people with only one remaining class were randomized to receive placebo or the drug for 8 days to see the antiviral activity, and then they optimized the background regimen. And individuals that didn't have any options, they were just directly randomized, or it was no randomization, optimized background regimen with this drug given twice a day. And these are the results. So the amazing thing is that 60% of the people at 2 years that didn't have only one class available were undetectable, which is an incredible result. Even the people that didn't have any treatment options, around 40% remain undetectable, which is pretty amazing for this in this situation. The other thing intriguing about this drug is that the rate of suppression, normally you reach your maximum around 24 weeks and then is a slope going down. The rate of suppression kept increasing after, and still the group is discussing why that happened and what is the mechanism of that, and there might be some immune mechanism when you prevent or you change because it binds to the GP120, the GP120 might become immunogenic. They are studying if that's the case. The other thing is that the people that failed, there was a significant amount, it was a well-tolerated drug, but this is a study that 20% of the people in this arm died. I don't know the last time I have participated in a trial there were any deaths. These people were incredibly sick, and there were a significant amount of deaths. Some of these patients were brought literally from no CD4 count, and they have a significant immune recovery. So this drug that has not been approved, probably will be approved late this year or early next year, I think will be a treatment option for people that don't have any treatment options, and really clinically we need that. I think beef had a problem with the manufacturing of the drug. This was a BMS drug, and then it became a beef drug, and they had to make a factory in Italy, and I don't know when it's going to be able to manufacture. And hopefully in the future we will have access to this drug. It's twice a day, so I don't think it's going to be first-line therapy, but for the people with few treatment options is a possibility. So in summary, it has been a very busy year for new drug approvals. I think the first-line therapy for most patients with HIV is clear. It's probably an integrase inhibitor-based regimen. There are caveats still to that for most patients with HIV, like the guidelines say, women of childbearing potential, what do you do in that case? If somebody wants to conceive a baby, do you recommend an integrase inhibitor, or do you recommend an alternative regimen? And I think in Mexico, and in the last 2 years, we have heard a lot about weight gain associated with the use of integrase inhibitors, and we need to understand it better and how it's going to affect the choice of the first drug. Are two drugs a treatment option? It's up to you guys to decide that. So we have new treatments and new formulations, and they continue to be developed. And the next 2 years are going to be as busy as the last 2 years. And we will have better options in the future for the patients with multi-drug resistance. And the future that is coming is intermittent therapy. Cabotegravir, rilpivirine intermittent therapy, broadly neutralizing antibodies, capsid antagonists. There is going to be this, I try to write here EFDA, but there's a typo there. This is the future of the antiretroviral treatment that we're going to hear in the next couple of years. Thank you so much.